Yeah, thanks, Brett. So this is a 59-year-old woman who you can see her distal tibial intra-articular injury on the left side. Um, for some reason, they opted for non-operative treatment, and then ultimately she showed up at about 14 weeks. And I think next slide, Brett. These were back from her original injury films. And so I think everyone can appreciate, this is a variant of a posterior pilon, and I think we have some CT images from this with kind of just the classic external rotation deformity, and it does involve about 50% of her joint. And just so we can I think go ahead and get to her um, non-healed subluxated ankle joint. Those are the original 3D CT scans. And this is what she looks like then at 14 weeks. And so I guess I'll just maybe put it out to the other panel members, what their initial thoughts are on this. She's actually, um, putting weight on this, but it's quite uncomfortable. But she does have some ankle stability.
I think for me, the main concern is that talus impingement on the plafond and how quickly that will go south if she continues to not get her joint stability addressed.
Yeah, this sure would have been a lot more fun 14 weeks ago.
Right. I mean, that is kind of like one of the more satisfying fractures about the ankle or tibial pilon variants is that pattern, because this is one of, there was no impaction. This was a pilon where one could truly get it perfect, right?
Yeah.
Yeah. So this is the CT scan that was obtained just a little bit before the I think maybe a week or two before. And it certainly shows what Brett referred to. I mean, the poor talus is just sitting right there on the articular edge as it's subluxated so far posteriorly. And you can see some callus formation within the gap of the original fracture. I think what you don't see well, though, or we certainly discovered intraoperatively, is right there is some callus, but I think it's impressive how much more healed this turns out to be than the CT would suggest. I mean, someone might look at that and say, "I'll just clamp it." Do not be fooled. Does anyone have any thoughts on how to attack this?
Yeah, I just think it's these are super hard at this point because getting that cleaned out is really the key. You can't get this closed down or get back to that sort of normal ankle anatomy that I showed in my talk, those cross sections, which is really impressive when you sort of look at the ankle in that view. To be able to close this down and get it back is really tough once you start getting that much callus in there. And then on top of that, the clamp really has to go from back to front. It's just a hard trajectory to get and not crush soft tissues and not have a big sort of clamp in your way. It almost has to be a plate reduction, pushing with the plate, but these are hard.
Yeah, I think the biggest question is, do you try to do it all through a posterolateral approach? I would be a little bit hesitant to only do that, because I think if you do a posteromedial approach, you should be able to, in addition, you should be able to see, at least distally, you're going to see the joint surface better, or at least get a peek at it as far as how well aligned it is. And so as long as their soft tissues could handle both approaches, I think that would be the exposure task that I would do.
And then Tim, how to regain length on these? Because she's been posteriorly subluxated and short now for quite a period of time.
Yeah, I think that, obviously your distractor is going to be very helpful. It becomes a soft tissue issue as well. I would start with trying to do a gastroc slide and see how much I got. I really am not a fan of doing an Achilles tendon lengthening, just because I think it really does weaken the overall system. And patients in the operating room, putting a lot of distraction on, and then trying to go and do something else, work somewhere else. I also like using a lamina spreader, sort of a poor man's distractor. I'll put, a 062K wire in the fragment itself, and be able to, with the lamina spreader and a couple cokers onto the K wire and the foot of the lamina spreader, be able to distract with a lamina spreader, then not necessarily in the fracture site, but just trying to gain length that way.
I was going to ask Mitch, since you are savvy with the circular frame, what do you think about doing gradual distraction and then coming back?
I probably would not do it here. Just from the lateral X-ray, for me, I think more of buttress mode, so posterior approach and buttressing the posterior malleolus. I agree with Tim's comments before. I think cleaning the fracture is difficult at the articular surface. Getting the apex of the deformity, I think, is not that big of a deal, but shutting down the fracture line at the articular surface is I've done two of these. I can't shut down the fracture line at the articular surface, but getting the ankle reduced is not that difficult. I agree with distracting the fibula, then distracting the posterior malleolus, using push-pull screws, and working that way. But closing down the articular lesion is very difficult.
All right.
All right, Brett. So I think everyone's point was good, and the shortening turned into quite a intraoperative project, in addition to trying to get callus out. And we certainly did have to recreate the original fracture with osteotomes, both through the fibula, as well as from cranial to caudal, as well as from the medial side. So we certainly started with the distractor. The second pin is through the incision directly posterior to anterior through the posterolateral approach. And we had to progressively did a gastroc slide right off the bat in addition to it. But I was probably struggling more with the reduction, but we did do a percutaneous tendo-Achilles lengthening. I couldn't do it because, like Tim said, it makes me feel ill. So I made Ben Ershka come in the room and do it, and then go back to doing a gastroc slide in room 14, which is what he does all day, in addition to complex problems. And then the problems that everyone identified, just recreating the fracture with an osteotomy, cleaning it. And you can see even with clamp applications, it's still not compressed. So to Mitch's point, clean for hours, and still it's so difficult to get that last bit of compression. And then I think we did go with independent lag screws and buttressing plates posteriorly, and the same thing with the fibula to assist with pushing that forward. But you can still see the slight articular incongruity. And then I think we have subsequent films of her immediately post-op, and then after healing, and that's her at 9 months. You can see her joint is a little bit sour already, even at 9 months. She hasn't had anything done subsequently. She's about three years out, but stay tuned.
Well, she's lucky she had you. Can I just ask a quick question on that medial fragment? Like, how did you see that? Did you externally rotate the posterior fragment to then be able to see and clean out that medial fracture line there?
Yeah, so I did the bulk of the work through posterolateral and posterior medial approaches, but then I also added a third small direct medial right over that component of it to free it up and to put in an osteotome right along that line. So that exit point at the anterior aspect of the medial malleolus.
Yeah.
Yeah, so I had to kind of have osteotomes in 3 different locations: through fibula, cranial to caudal, and directly medial.
So I think the take homes were that the CT scan's critical, gaining length, even sometimes if it's 2 weeks, can be really challenging in these fractures. Utilizing the previous fracture lines are really helpful and kind of give you the plane that you need to go through, and then using standard fixation principles like Mitch said, getting buttress fixation and then also compression across the joint.